Good evening. My name is J.R. DeShazo, and I'm Dean of the Lyndon B. Johnson School of Public Affairs. And it's my great pleasure to welcome you all tonight to our symposium entitled Texas's Reproductive Health Policies, A View from the Frontline. Tonight, you're going to hear from a panel of doctors and experts who have been on the front line as Texas has implemented two important abortion policies. The first is known as the Heartbeat Act, SB 8, and the second is called SB 4, which limits women's access to medication that allows them to self-manage abortion. Discussions of abortion evoke intense emotions on all sides. And this has been a policy space where a lot has been happening of late. This weekend marks the 49th anniversary of Roe versus Wade. The Texas policies that we'll be discussing tonight are under review by courts at all levels of government. Our democratically elected leaders here in Texas are likely to consider future policy changes. And of course, policy leaders in other states are also likely to consider changes to their abortion laws. This is why it's important for public universities like the University of Texas to fulfill their role in providing up-to-date and credible information on the policy impacts of policies like these. Our mission tonight is to share our knowledge with health practitioners like you in the audience tonight, and also to share this information with our elected leaders and the citizens of Texas who may use this information in their deliberations about future policy changes. Our panel tonight is going to address several questions. They're going to discuss how SB 8 and SB 4 are meant to be implemented. And then they're going to describe a variety of different impacts of these policies. Specifically, they'll discuss which women and which communities are most likely to be impacted, how women who become pregnant have responded to these new policies, and how doctors who deliver healthcare to women have been impacted by these policies. After the panel discussion, you, the audience, will have an opportunity to ask questions of our panelists. And before I introduce our moderator, I want to thank our panelists for sharing their experience and expertise with us. I'd like to thank the Dean of the Dell Medical School, George McCombs, for his support of tonight's event. And now it's my great pleasure to introduce tonight's moderator, Dr. Jewel Mullen. Dr. Mullen is the Associate Dean of Health Equity and an Associate Professor at the Dell Medical School at the University of Texas. She's also the Health Equity Director at Ascension Seton, an internist and epidemiologist. Dr. Mullen is a healthcare leader who has served as the Principal Deputy Assistant Secretary for Health in the U.S. Department of Health and Human Services. Dr. Mullen, thank you so much for serving as tonight's moderator.
Dean DeShazo, thank you for inviting me and giving me the opportunity to be among our panelists who are the experts in this discussion. I really appreciate it. And also as a primary care doctor, feel extra privileged that you guys let me be a little bit of this conversation. And I really want to be in the background as you all do more of the talking. But I wanted to follow on with your opening remarks to state that Senate Bills 8 and 4 and other laws have evolved in a broader state and national policy context or environment that many people have referred to as increasingly restrictive and inequitable. And while abortion access may be our major focus tonight, it's not the only issue that our panelists or anyone is actually thinking about. And in that regard, I understand that the LBJ School team has compiled a fantastic list of resources for anyone who's interested to do deeper exploration of a number of topics. Among those is a policy evaluation paper by another UT Austin expert, Dr. Carrie White at the Steve Hicks School of Social Work, who has at least 2 policy papers written in 2021. And the one I'm referring to assesses public funded reproductive healthcare policy and programs and their impacts on particularly low-income women between 2011 and 2021. So as we frame the discussion in the broad context of reproductive health policy with the primary goal of explaining Senate Bills 8 and 4 and discussing their impacts on medical care, healthcare, the people who provide it, people and communities in general, I want to start with some orienting concepts. We're talking about reproductive health policy. So I offer you that the World Health Organization defines health as the state of complete physical, mental, and social well-being, and defines reproductive health as a complete state of physical, mental, and social well-being in all matters related to the reproductive health system, its functions and processes. And that implies that people have the capability to reproduce and the freedom to decide if, when, and how to do so. I wouldn't be the Associate Dean for Health Equity without then including a definition offered by the Coalition to Expand Contraception Access, a definition of reproductive health equity, referring to systems ensuring that all persons of every age range, gender, race, and other intersectional identities have what they need to attain their highest level of sexual and reproductive health. It's not because I'm anything other than somebody who likes broad conversations that I want to remind people a few things. One of which is that as we have these conversations, please let's remember that implementation of effective, comprehensive, accessible reproductive health services and programs lowers rates of unintended pregnancies and abortions. Number two, that perspectives and policies that limit access to healthcare, including abortion services and reproductive health services, disproportionately affect adversely women who are low income and members of racial and ethnic minority groups or who reside in areas of high social vulnerability. And it's probably impossible to talk about policy without having it sound political to people, and that's okay. But please also remember that this is not a partisan or politically motivated discussion. And hopefully you'll be able to make the best of this really important information from our panelist experts, who include Dr. Abigail Aiken, who's the Associate Professor of Public Affairs and the Fellow and Richter Chair of Global Health Policy at the LBJ School of Public Affairs. Her research focuses on unintended pregnancy, evidence-based obstetric practice, and the impacts of laws and policies restricting access to abortion, including how and why people self-manage their own abortions outside the formal care setting. Like our other panelists, she is internationally recognized and sought after for her work. Next, Dr. Lauren Thaxton, a board-certified obstetrician and gynecologist and assistant professor in the Department of Women's Health at Dell Medical School. Her research focuses on patient-centered care in contraception, abortion, and outpatient anesthesia. Dr. Lori Harper, associate professor in the Department of Women's Health and division chief for maternal fetal medicine at Dell Medical School's Women's Health Department, is our third panelist. She's currently involved in a number of clinical research projects investigating adverse outcomes in pregnancy. They all have doctor in their name, they all have expert in their name, they all have passion in their work, and they have all have expertise that leads me to get them talking and not me. So thank you to our panelists. And I'll start then with Dr. Aiken, and I'm happy to be called Jewel if we can all call ourselves by first names or just say what you want. Given the policy context and evolution that I referred to, would you talk about how the changes over the past decade have shaped your work and your perspective as a policy expert, how it's influenced your research, your collaborations, the kind of advising you're asked to do, and your advocacy?
I Really, in the last decade, we've seen a lot of policy changes in the reproductive rights arena here in Texas. We have seen access to abortion become ever more difficult as clinics close and as people have to go through more and more barriers to try to access care. At the same time, we've seen our contraceptive safety net dismantled, and although work has been done to try to piece that back together, it's difficult to put back a patchwork. And so particularly folks living with low incomes still oftentimes struggle to access the contraceptive care they need. And then on top of that, we know that our maternal mortality rates are too high. And we know that even though the average number is too high, there are also stark inequities within that number, with Black women and Black folk who are pregnant 4 times more likely to experience maternal mortality than other groups. So there is a lot of work to do. And I lead the Project SANA, the Self-Managed Abortion Needs Assessment Project here at UT Austin. And we are looking at how people are accessing abortion outside of the formal healthcare setting. They are self-managing their own abortions at home. And although self-managed abortion has been around since there were people in North America, the way in which people self-manage, the reasons why they self-manage are directly related to what our policy environment looks like. I'll be talking more about that later. And I think it's also worth saying in terms of my collaborations and those that I try to train, there's never been a more important time for reproductive justice to be part of our conversation because of these stark inequities that we see in our communities with people of color, people living with low incomes, people who are non-binary or gender non-conforming, people in immigrant communities. We really need to be paying attention to how access is oftentimes not working for those people. So what happened recently with Senate Bill 4 and 8 didn't appear overnight. It really is part of a long arc of where we've been headed policy-wise for some time.
Thank you. And I know in this decade's timeframe that we talked about, Dr. Thaxton, you've also come from New Mexico over to Texas. And I'm wondering if there's something you'd like to add, particularly from your clinician, doctor perspective, how your work has been impacted, especially as an expert in complex abortion and contraception care.
Much, Jewel. Yeah, when I think about the last decade, I think about where I was a decade ago. I started my residency training in 2011, so just a little over a decade ago. And as I was going through my intern year, I wasn't thinking about policy. I wasn't thinking that I was going to have any expertise in policy. I was drinking from this fire hose of medical information that is residency and trying to take that information, that medical knowledge that I was drinking, and use it to provide the best care for the patient that's in front of me every day. And then during my residency training, like you said, I was in New Mexico. And so I saw the effect of very restrictive policy changes in Texas. So HB2 going into effect. I saw the lived experience of that policy change during my residency. So as an OBGYN resident training in New Mexico, I saw Texas women who drove 10 to 12 hours to talk with a doctor about their decision to have an early abortion, have their early abortion, and then drove back home right after, all in one day, so that they could be back home in order to be home when their children woke up in the morning. And I have done that drive myself, and it is long and lonely and difficult. I saw couples with desperately wanted pregnancies who would, talk with their OBGYN in Texas, board a plane, and come to New Mexico to be able to have an abortion for a pregnancy that was very wanted, but suffered from terrible complications. And that couple saw an abortion as an act of love and compassion for a suffering pregnancy. And so it was hard seeing those cases as a resident. It was hard seeing that policy impact. But it was also hard knowing that I was only seeing a small fraction of the patients that existed. I was only seeing the patients who were able to travel for care. I wasn't seeing the patients that weren't able to make that travel. And so here now today, where I stand today, I've been in Texas for 4 years as an OBGYN, and every day I sit with someone and know that their care is determined not by what they would want or what's best medical care and shared decision-making with me as their doctor, but whether they can jump through a series of increasingly narrow hoops. As Dr. Aiken kind of talked about, that patchwork of healthcare that we have here. And just to kind of put that to a story, just the other week, I saw a patient in clinic who wanted to be sterilized after the birth of her child. And after I talked to her about the surgery and the risks and benefits, I also talked to her about logistics of how to accomplish that sterilization surgery. And that conversation of logistics was at least as long as and more complicated than the conversation of the medical procedure. I talked to her about where she plans to deliver, because there are some hospitals where she wouldn't be able to obtain that procedure because they don't offer that surgery. I talked to her about signing specific paperwork and forms that must be done at least 30 days before her delivery. I talked to her about the possibility that, she could have complications during her birth that prohibit her from safely having that surgery, but also the hospital may be busy and understaffed, which is an increasing reality as this pandemic continues. I also talked to her about, if she doesn't get this surgery during the hospitalization after her birth, that her insurance, knowing what her insurance was at the time of her pregnancy, and knowing that it will very likely change shortly after her delivery, that she may lose her insurance and that she may need to start this whole process over again. And so if any of you are struggling to kind of follow this process, so does my patient. These hoops are even more narrow, and there are even more of them as we think about a person who desires an abortion. Today, in order to provide a patient that I've counseled about an early abortion, I have to perform a medically unnecessary ultrasound, draw medically unnecessary labs, tell them state mandated information about associations that don't exist in best medical science. She needs to see me back 24 hours later. She can only see me. She cannot see a coworker that has the exact same training as I do. And that follow-up appointment has to be at least 24 hours, no sooner, for her abortion. So if her labs get lost, if I become ill and can't come into clinic, if she can't come back the next day because maybe her work doesn't give her time off, or she can't arrange childcare, in any of those situations, she's faced with either traveling out of state for her abortion care, in all likelihood, given the narrow window to be able to offer abortion care right now, or being forced to continue her pregnancy. And this isn't best medical care, and it's not the medical care that I would want for myself. It's not the medical care I would want for my sister, my friends. It's not the medical care that reproductively capable people are receiving outside of Texas.
Thank you. Thank you for sharing that. And so, Dr. Lori, Dr. Harper, you don't know this, but in our preparatory conversations, I started thinking of you as a doctor's doctor and a patient's doctor, which might sound sort of redundant, but part of that is your leadership role, and part of that is also the way you talk about your work and patients. And so I could just say, in the interest of time, let's move to another question, but I want to hear what you have to say.
Thank you. So I'm a maternal fetal medicine specialist, and I just want to pause and clarify what that means. It means that my job is taking care of complicated pregnancies. So I take care of women who either had medical problems before they got pregnant that they knew about, or who, because they didn't have medical care before pregnancy, didn't know they had those problems and got diagnosed at their first or second prenatal visit. because now they have medical care and we're diagnosing things in those women. I take care of women whose pregnancies are complicated by birth defects or anomalies. And I take care of women whose pregnancies become complicated from something related to the actual pregnancy. So they develop preeclampsia or they break their water early. And for me, an abortion, the plain fact is that abortion is important and appropriate medical care for some women. So it doesn't matter how desired a pregnancy is, or if it was planned or unplanned, or they were on the best form of contraception before they got pregnant and they just still got pregnant. Some women just cannot take the stress of pregnancy. So they may basically die or develop a life-threatening condition because of pregnancy. In those cases, I have to recommend an abortion in order to prevent a maternal death. And that is getting much harder. In terms of birth defects, when there are gestational age limits, sometimes those gestational age limits are too tight to firmly diagnose a birth defect, where patients may desire pregnancy and decide to terminate because what they want is a baby that goes home and survives. They don't want to have to carry a pregnancy that is going to die immediately at birth. For me, limited access to abortion just means that women are going to die because we can't access appropriate medical care. And between SB8, which is the fine or the penalties are a lawsuit, and SB4, where the penalties are actually jail time, physicians are having to choose between their own personal well-being and at times a patient's well-being. And that's not appropriate for to put anybody in. And I really can't think of any other procedure that's life-saving that is regulated by Texas, by any state law like this. And to really put it into perspective from a patient standpoint, there was actually very recently a pretty well-known case. In 2020, Poland actually passed a near total ban on abortions. And so the woman's name was Isabella. She was 30 years old and living in southern Poland. Her fetus had been diagnosed with multiple birth defects and her water broke when she was 22 weeks. When water breaks that early in pregnancy, the typical recommendation from an obstetrician is to offer termination because of the risks to mom, which include maternal sepsis, abruption, and death. So prior to treatment, Isabella sent a text message to her mother that says the baby weighs 485 grams, which in a normal healthy baby is right at the cusp of where a baby could start to survive potentially, but probably not for a baby with multiple defects. And she goes on to say, for now, because of the abortion law, I have to lie down. They can't do anything. They're going to wait until he dies or something else happens. Oh, and also I could die of septic shock. She developed an infection, and physicians refused to terminate the pregnancy while the fetus still had a heartbeat. And after a stillbirth was confirmed, doctors agreed to terminate the pregnancy. And she died on the way to the operating room. So this was a well-publicized, very famous case in Poland. And so after her death, Poland's health ministry clarified the nation's abortion law, insisting that the procedure remained available to save the life of a pregnant woman. And I haven't actually read the text of the law. I don't speak that language, but I would say that theoretically Texas's SB8 provides exemptions for the life and health of the mother, but when physicians are fearful of punishment, they may interpret the law in the same way and risk patients' lives. So when abortion is not readily accessible, we're just risking women's lives, and the end result is going to be an increase in maternal death.
Thank you. Thank you. And I want to build on where you just left off to give us a chance to get into some more specifics so that people understand the detail the policy changes that first SB 8 and then we'll move to SB 4 actually represent. So I'll bounce over to Lauren for a minute and say, would you like to start to describe that? I imagine Lori will have more to add, and then probably Abigail too.
Yeah, I'm happy to get us started. They're both complicated laws with a lot of facets, and so happy if Lori or Abigail want to hop in at any point. I guess I'll start off with SB 8. So this is identified as a Heartbeat Act, and what this requires is that in addition to all of the other pre-existing state mandated policies on abortion care in Texas, and layering on top of it that in order to provide an abortion 24 hours before that abortion, we need to date the pregnancy by ultrasound. That was pre-existing before SB 8. But if during that ultrasound we identify cardiac motion, which typically occurs somewhere in the 6th week of pregnancy, that we can no longer offer an abortion for that patient in the state of Texas. So that very narrowly defines a gestational time frame. And sometimes I think it's confusing 6 weeks, what that actually means. And so I think there's been a lot of media work around this, which is great. It is confusing how we date pregnancies, but that is typically only 2 weeks after someone's missed a period. So it is not often that someone knows that they're pregnant that early. SB 4 is is primarily focused around one of the evidence-based options for abortion care, which is medication abortion, which involves 2 medications, mifepristone and misoprostol. And SB 4 restricts the time frame where we can use those 2 medications for medication abortion to be more restrictive in gestational age than is evidence-based or is approved by the FDA. And so those are kind of the broad brushstrokes of both, and I'll leave it to Lori and Abigail to speak up about more details.
So SB 8 does not have any exceptions for rape, incest, or fetal anomalies, life-limiting or including life-limiting fetal anomalies. It does make an exception for medical emergency, and I actually just always have to write down exactly what it says, but it says do not apply if a physician believes a medical emergency exists. And so there are a couple of special points about SB 8. One is that abortion is actually clearly defined in a Texas statute as the intent to cause the death of an unborn child of a woman known to be pregnant. So to be very clear, an act is not considered an abortion if something is done to save the life or preserve the health of an unborn child. It's not an abortion to remove a dead fetus already caused by spontaneous abortion. So it doesn't apply if you're managing early pregnancy failures. And it does not apply to remove an ectopic pregnancy. So ectopic pregnancies, early pregnancy failures can be safely managed. You shouldn't be afraid of being sued under SB 8 for those. The other point I wanted to make about SB 8 is that it does explicitly in the law recognize a physician's First Amendment rights, doesn't prohibit our free speech. So you can say appropriate medical counseling to a patient. I think a lot of the fear around this law comes from the aiding and abetting portion of the law. And there was concern, I think, from a lot of parties that just talking about abortion would get you into trouble, but the law does explicitly refer to a physician's First Amendment rights. And then there's the medical emergency exception, which is not very clearly defined and can be sort of broadly interpreted or narrowly interpreted. But in the Texas statute, a medical emergency is defined as a life-threatening physical condition aggravated by, caused by, or arising from pregnancy that places the woman in danger of or serious risk of substantial impairment of major bodily function unless an abortion is performed. So it's open to broad interpretation, but I wanted to clarify, since I know there are a lot of physicians here and we tend to have a different interpretation of what the word emergency means. It doesn't necessarily mean you're running a code right now and can perform an abortion. There's a little bit broader of a definition of an emergency than that.
So I also want to give Abigail a chance to weigh in, but as a doctor and former policymaker, you just make me wonder whether or not a broad, not explicitly defined term is a good thing or a bad thing in the context of having to justify or defend medical practice. If you end up in, and where I'm going with this in part is whether one has to worry about justifying how they defined a medical emergency. Just wondering out loud.
You know, I think from a patient perspective, what's going to happen is it's a little bit of luck of the draw, which doctor you find. And if you have limited access to physicians and the physician that you get assigned to in your federally qualified health center that day says, nope, can't do it, then you're a little bit stuck. And if you have some privilege to be able to doctor shop, then maybe you can get an abortion that you really need. I think from a physician standpoint, you know, some of us are a little bit of rule followers, and that broad definition, while that exemption exists, because of the civil lawsuit nature of this and how it's interpreted, leaves us feeling very open to lawsuits and are very at risk, even when we feel that the procedure is medically indicated and justified.
Do you mind if I jump in, Jewel? I was just going to tag along to everything that Lori said so beautifully, and just make the point that we went to medical school, we did not go to law school. So, you know, there's a very real threat that's being placed on medical care providers in this context with this law. And I completely understand the fear that providers, and I want to use that word broadly because we're talking about doctors, but it also applies to ultrasonographers, nurses, ER staff, medical assistants. And there's a very real threat that's being placed already in a system where people are fearful of COVID and everything else that's going on right now. There's a lot of stressors being placed on medical care providers. And so I completely understand these fears that people have. And I also think it creates unsafe differences, exactly as Lori was saying, in what care patients receive based on who they see and how knowledgeable that person that they see is of the legal landscape, of you know, what falls into and doesn't fall into this law. And whether or not a patient gets full evidence-based informed information to make their decisions will be determined by who they see.
Abigail, no pressure, just the opportunity.
Thank you. Yes, I'll switch tack to Senate Bill 4 since we've talked about that less. As Lauren already pointed out, Senate Bill 4 does narrow the window in which physicians are allowed to give mifepristone and misoprostol for a medication abortion from 10 weeks down to 7 weeks. And then it also prohibits the mailing of abortion pills, so by courier delivery or mail service. And it's really worth noting that both of those things are in direct contravention to what the FDA says is the best scientific evidence-based practice for providing medication abortion. It was several years ago that the upper gestational limit was increased from 7 weeks to 10 weeks. And in fact, we do even have evidence that medication abortion can be effective beyond that, although that will take time to percolate through the policy systems. We may see another increase in that later, but it's certainly different from what the FDA is recommending. And during the pandemic, the FDA also lifted one of the major restrictions on mifepristone, the first medication in the medication abortion sequence, and allowed it to be prescribed following a teleconsult and then mailed to a patient's home. And if you can imagine what that means for patients in terms of not needing to take time away from work and school and childcare to make appointments, to come to clinics, especially with COVID transmission being a possibility, for both patient and provider. And so the FDA very recently ruled that telemedicine for medication abortion is now something that they support. I think that when you look at how this bill is framed, it's very much framed in the sense of protecting pregnant people and pregnant women, the idea that medication abortion is somehow unsafe, that it is likely to result in death or serious injury. And we have decades of evidence at this point in direct contravention to those statements. We know that, in fact, medication abortion is one of the safest procedures there is in really all of medicine. And so when you look at what SB4 is designed to do, it's really designed, I think, to put barriers in the way to accessing this form of abortion care. It's also not totally clear how you would enforce the idea of prohibiting the mailing of abortion pills. Short of going through folks' mail, which I believe is a federal offense, I don't think it would be easy to enforce that. But I think what it will create and has created is something of a chilling effect. If you imagine being someone in another state who might want to post abortion medications to someone in Texas to help them out, or if you're an abortion service that is providing medication abortion through telemedicine, as we know, there's been a growth in those services since the FDA has loosened those restrictions, and some are operating centrally in many different states. But I think it's designed to stop them from starting to, try to practice medicine across state lines, try to mail abortion pills into Texas. That does not mean they don't get there. There is an online telemedicine service called Aid Access, which is actually based and run from outside of the country. And they do mail medication abortion pills to people in Texas for the purposes of self-management.
The other point to make about SB4 is the way that law is worded is they were really trying to cast a wide net so that people couldn't sort of fly under the radar, sneak in a medication abortion, and it is targeted at elective medication abortions, but it is written so broadly as to say any abortion-inducing medication, which these are medication, not mifepristone, but misoprostol, is used to induce pregnancy at pre-viable gestational ages in these life-threatening conditions. And while that's not the intent of the law, that is in fact how the law reads and makes no medical exceptions for the life or health of the mother. So I've actually had to make a lot of phone calls about what does this mean for the practice of obstetrics.
Thank you for all that clarification. And then you have said misoprostol and mifepristone numerous times. And as a primary care doc and a person and just somebody who reads polls, I was still surprised to read that at least 2/3 of the public believe that emergency contraception, things like Plan B, end pregnancies. So experts, can we like maybe say something that can be tweeted out from the LBJ School to debunk that? Anyone, please.
I'll start, but you guys feel free to pipe in. Emergency contraception and medication abortion are two completely separate things. I'll start. That's the tweetable tagline, but medication abortion utilizes mifepristone as a medication that's taken orally. So you take it by mouth and then followed by a second medication, misoprostol. It can be administered in a couple of different ways, but basically when you take that misoprostol, that causes bleeding, cramping, and passing of a pregnancy. That is a different process from emergency contraception or post-coital contraception, after sex, contraception, morning after pill, all of those things as a conglomerate. those medications are used immediately after someone has unprotected sex. So for instance, you have sex, the condom breaks. You have sex, you forget to use a condom. You have sex and forgot to take your birth control pill that day. You can take that pill as soon as possible after having sex, and it delays ovulation to reduce the likelihood that in that single event of sex that you become pregnant.
Thank you for providing public education, which is an essential component of reproductive health care, enabling people to manage their own choices at the right time. Thank you for that. I want to ask before we move on, is there anything any of you else you would like to say specifically about SB 8 and 4 before we move to some other related considerations?
So regarding SB 8, the other thing that it is now limited is some procedures that are potentially life-saving for a fetus. So there are some very special cases, and they're pretty few and far between, of twin and triplet pregnancies where one fetus is in danger for some reason or can't survive for some reason. And because of the way those fetuses share placenta, it jeopardizes a healthy fetus. And so there are centers in Texas capable of doing procedures that can save the life of the healthy co-twin, but at the cost of the unhealthy fetus that can't survive. And so after SB 8, those procedures stopped being offered in Texas. And so when patients have those complicated pregnancies, they have to leave the state to save the life of their other baby, the healthy baby. So that is, I think, another just unintended consequence of this law.
You've touched on this already, innately. Is there anything else that we should be thinking about from a reproductive health equity perspective that you would like to mention?
I'm happy to start off with that question. I appreciated that you started us off in the beginning talking about like defining what is reproductive health equity. And these, I think that that's a really important point to outline here with these policies. They're policies that place barriers between people and their doctors or their medical care providers, their plan of care. But they layer on top of systems of marginalization and oppression that already exist in our healthcare system. And so the result of that is that the effects are not felt evenly. They are felt more by people living in poverty. They're felt more by minors. They're felt more by people with disabilities. They're felt more by trans, felt more by people with limited transportation or childcare options, people living in fear of intimate partner violence, people living in fear of deportation, people who don't speak English as a first language, people with limited social capital. All of those things are risk factors for being further affected by these policies.
I'll jump onto that and say that I think what Lauren says translates directly into what we see people go through, because in our research, we've done a lot of interviews with folks in the wake of Senate Bills 8 and 4. And while some folks are able to get out of state to go seek abortion care, for example, elsewhere, and abortion funds and out of state clinics have been working around the clock to try to help people to do this, the folks that are most reliant on self-managed abortion tend to be the folks with the fewest resources, the folks with the least support. And while self-managed abortion can absolutely be a legitimate and affirming choice for somebody, when it is not a choice, it can also be a very isolating very difficult experience, and not one entirely without legal risk either. And so we do see this translated into the impacts on people. I think it's also worth taking a moment too to see how what's happening in Texas reflects what we are starting to see happen more throughout our country. You know, the process of policy diffusion we talk about in the policy world, where other state legislatures look at what's happening in Texas and they think we could do something like that in our state too. And as we note that, you know, the FDA is starting to make access to abortion, for example, more accessible, we see states where legislators don't want that to happen, doubling down on restrictions. So this idea of unequal access inequity is becoming ever more divergent between states, and we're starting to come to a picture where, you know, we have to look beyond our own state to sort of ask, what are the consequences of this at a national level?
Thank you. Building on that, thinking about what's happening from state to state, you've already talked about people needing to traverse state borders for care. There are also examples of physicians, clinicians who traverse state borders to provide care. So let's then think some more, because I think it, you know, what you'll see is I should tell our audience that I am paying attention to the questions that are coming in, and I'll foreshadow for our panelists. Some of the questions almost come across to me as, you know, maybe a quick medical consultation based on your expertise for people who are also puzzling through how to care for their patients, and others are more policy related. And in that light, you know, would you talk a little bit about the legal risks that out-of-state doctors who prescribe these medicines face, and the legal risks that people who use them face?
I can begin on that. You know, it is a very gray area a lot of times for people who do self-manage, for the following reason. You know, we don't have a state law in Texas that would criminalize a person for conducting their own abortion or conducting an abortion with help from somebody outside of the formal healthcare setting. And there are a few states in the United States that actually do have any of those laws. Where they exist, I think in 5 states, they are relics from the 19th century. They are not new laws. They are just kind of sitting there on the books. However, this does not mean that prosecutions have not happened. And they tend to be prosecutions where prosecutors will allege that somebody has self-managed and then use the spaghetti at the wall type of legal strategy to see what can I do to stick this on this person? How am I going to prosecute them for this? It's unfortunate that we have that appetite for punishing pregnant bodies and pregnant people in this country, but we do. We live in that climate. And so it is not without risk to the person, even though there is no explicit statute that would criminalize a self-managed abortion in this state. The main route of abortion pills coming into Texas, as I mentioned, is from really outside of the country. But those folks, although they are indeed not complying with Texas state law, it is hard to see exactly how to make that an issue when they live in a different country or state. So, you know, I think they view themselves very much through a human rights lens. And while there's a need, they will step up to provide that.
Thank you. I know we're going to be getting to the Q&A quickly, and still peeking at some of what's coming in. I think it also directs me back to where we began, which you've in part alluded to throughout all of your comments, which is the broader reproductive health policy environment that everybody who's here in one way or another thinks about, cares about, has opinions about, and is trying to navigate and understand. And you're experts, but I would never walk away from this conversation and say, all you care about is SB 8 and 4. And that's, you know, that's all you do, and that's all you care about. And we've all lived in a time, through times when laws get passed and we keep doing our work, right? But we shift. So that means we shift in ways in which we can deliver care, we amplify other policies and practices we care about. So today, I'm not necessarily feeling like we're going to change the world, but in the meantime, what do we want people to keep in mind alongside SB 8 and 4 that is really, really important, particularly if we, as many, believe that while the care, abortion care, is part of medical care, access to other medical care actually, in many circumstances, decreases the need for abortion. What might people miss? What else beyond that little tweet about emergency contraception? What else should people, and what would you want to see upheld or remembered or better access for in terms of policy and program?
I could start us off. I think that you outlined something that was very important, which is that SB 8 and SB 4 didn't happen in a vacuum. This is a pattern of increasingly restrictive healthcare policies, and they limit healthcare in reproductive health in more ways than abortion, healthcare after birth, contraceptive options, confidentiality in reproductive healthcare, the clinics that are available to provide reproductive health, and the resources that are available to those clinics. So I think it is an important point to say that we need to do better to streamline and provide comprehensive reproductive health care coverage to all Texans. And especially going back to that equity argument, especially those at highest risk of not being able to access care, that we need to provide resources for continuity of care and meet the needs of the clients that we serve. At the same time, I hope one of the things that we have conveyed today is that pregnancy, as a clinician, pregnancy is complicated, it's nuanced, and things can change on a dime. Anybody who has ever been on labor and delivery before knows that you have no idea what you're walking into when you walk into a delivery shift, and you won't know from 1 minute to the next because things change. And so you made the point of planned pregnancies, unplanned pregnancies. And I want to make the point that while almost half of pregnancies are unplanned, that doesn't mean that they are unwanted. And some pregnancies that are planned become abnormal, threaten the life of the mother, have an abnormal fetus. And so what can start as an uncomplicated or binary case, or what is never a binary wanted or unwanted, planned or unplanned case, can turn, can change in one way or another. And so having access to abortion is always going to be a necessity. And having that be not just available, but accessible to all pregnancy capable people is the only way to have a safe world for pregnancy capable people.
I think also, to piggyback on that, one of the things that comes through most strongly in our research and in our work with our reproductive justice leaders in the Austin community and in Texas is that, yes, it's about abortion, but it's never, as Lauren said, just about abortion, right? When we think about somebody's reproductive life and we think about the pillars of reproductive justice, we're also talking about the ability to have the family that you want to have or not, right? The ability to get pregnant or avoid pregnancy, the ability to parent without fear, and in a way that is acceptable to you. And when we think about that as a goal, like being able to choose parenthood and be able to choose parenthood on your own terms, we're talking about even much more than reproductive health policy, right? We're talking about economic policy. We're talking about social policy. We're talking about structural institutional racism. I know we set out not to change the world with this conversation, but we do have to look broadly at the context of in which reproduction sits in people's lives. Start thinking about how to pay people at least minimum wage, how to make parenthood possible for people in terms of the leave that they might need or the supports their family might need, how to make reproduction possible for people for whom it is a struggle to have pregnancy occur in their lives also, and to really start thinking about how to put all of those pieces together so that everybody has the ability to create and then implement whatever their reproductive life desires might be.
Well, Abigail, I'll go there with you anytime. You want to change the world, I will go there with you anytime. And so can I answer my question too? Because one of the things I was thinking as we sit here at the University of Texas at Austin, promoting knowledge and inquiry and discovery and disseminating it is how fundamental education is. And in my first year at the medical school, I think my first foray into community service was joining the school health subcommittee for Austin Independent School District, where that year there was a lot of work being done to revise the comprehensive relationship and sexual education curriculum. And because I was a doctor on a college campus earlier in my career, I understand how important it is for everyone to understand their bodies and how they work and what they do for them, and to get access to that information. So, just thinking about, everything that you said, Abigail, and what everyone has said, is that the ability to actually be activated and exercise the choices that you want also hinges on having the information and the accurate information to be able to do so across the lifespan for what's appropriate for you and for who you are. So thank you for letting me say that and add that. Let me just ask Dean, JR, we have 15 minutes left, and I know we started late. I was going to actually move to questions if you're comfortable with that too, but since I took the prerogative to say something, I'm going to turn it on you. Is there anything you want to add to this conversation now that you've had a 1 hour introduction?
Jill, thank you for that opportunity. I want to give our audience, since they have persevered and posted now over a dozen questions, a chance to have some of those answered. So my suggestion would be that you take the questions that you think are most impactful.
Okay, thank you. And I will then, and I'll start with this one. It was the first one that came in, but as a doctor who practices within rules and is a policy adherent, I've also been in a situation where I felt badly because I couldn't necessarily do what people asked me for. So the first question, actually, in addition to telling you how terrific you are, was one about how clinicians and how you address patients who come to a clinic, a care setting, and then see you as the people responsible for restrictions that you didn't actually create. And how do you handle that?
Thank you for that question. That is my everyday. I will say that, we provide, as Lori kind of discussed, we provide evidence-based medical information for every patient that I see. I also provide them the information about what of that care is accessible in Texas or not. And that is very difficult as a physician to have the training, have the skills, have the clinic space materials to provide a patient with evidence-based healthcare and not be able to do that. So that's my answer to that question.
Thank you. Thanks.
I found one thing that I really try to emphasize with patients, and it's not actually any type of deflection for me, but to tell them that even though you can't get it in Texas, it doesn't mean it's not the right choice for you if you can go elsewhere to get it. I found that many patients feel that because they can't do it in Texas, that it must somehow be a personally wrong decision or that they're doing something bad. But I try to emphasize that this is a specific Texas law and they can still access abortion, just not here.
Thank you. And as I go through some of these questions, I think I just want to qualify that I'm trying to present them to you in ways that don't turn this Q&A into medical consultation that people will say, you advise them what to do, or that are just so personal about your practice or UT and Dell Medical School's practice. But I imagine that there are colleagues across the state who work in state institutions who wonder what kind of legal protections they have in the event that somebody does accuse them of breaking a law. And if you don't have the specific answer, then perhaps that's something that we can provide as additional information later. But if there's something quick that you can offer that you know, take it.
I'll just pipe in and reiterate what I said before, which is we are not lawyers. And everybody's system is going to be different and unique, and your healthcare practice is going to have its own legal team and meet with your own experts in your own system.
Thank you. Thanks. Another specific type question is just asking for some differentiation around the proportion of women who present with medically urgent with medically urgent conditions who might need an abortion for a medical emergency versus those who are seeking an abortion more just in the context of having an unplanned pregnancy that they don't want to continue. And is there a breakdown in what you see in your practice?
So by the time they get to me, it's typically an established pregnancy for which they're seeking care and have chosen to continue. So in my personal practice, all abortions that I discuss and talk and recommend are medically indicated, but I don't know a statistic off the top of my head of all abortions performed, what was medically indicated versus what was elective. And I think part of the problem at getting at that answer is that medically complicated pregnancies tend to frequently have hospital-based abortions, which may not fall under the same sort of statistics and monitoring that elective, quote unquote, abortions have. But I don't know if Lauren or Abigail know the answer.
I don't know specific statistics to get at what the heart of that question is, I would say. But I think it is also a very difficult thing to put numbers on, as we've talked about. All abortions are indicated. How do you kind of go through all of these nuances and sort into very neat stacks which pregnancy is urgent, which abortion is urgent versus non-urgent, which abortion is, this or that. So it is hard to measure that question.
Thank you. And I just want to say, having earlier today, had a wonderful meeting with our Dell Medical School librarian, and she knows I love librarians and library and information science, that in the chat, Imelda Better actually posted a link to a CDC website that has some statistics related to that very question. Thank you, Imelda. Another question gets back to the whole point about medical emergencies. And I think this is just wondering your opinion. Since there can be different interpretations around medical emergency, could it be of benefit? And maybe this would be something you would talk about in your professional society. Would it benefit a physician to have a second or third physician who agrees that there is an emergency? And that's the first part. And then the second part is, do you see any positive or silver linings that could come out of these policies?
I can start with just a very general answer and then hand it over to Lori to that first question, which is the hospital system is going to have to, or each clinical practice is going to have to think about how they are going to manage these emergency exemption cases. And one of the propositions is typically having a second physician or a team of physicians or a board of elected members approve these cases. I think Lori pointed out very well in the beginning what happens when we add these additional layers of check boxes for people to pass through when we are by definition treating an emergency. These are sometimes conditions that do not have the benefit of time. And as Lori discussed with Isabel's case, sometimes passing through a case with a second physician, sometimes passing through a panel of more physicians creates critical time delays in treating our patients.
So in addition to the time delays, one of our issues is that a lot of these things are a matter of medical judgment and opinion. So I can't necessarily give you a good statistic on, for example, in Isabella's case with rupture at 22 weeks, I couldn't put a number on her risk of death or her risk of sepsis or her risk of abruption. It's there, it's real. I'm sure it's measurable, but I couldn't tell you an exact number off the top of my head. And if I did have an exact number, it would have a pretty wide confidence interval, a range of numbers that the real number could actually be. But then it boils down to what number is acceptable, right? So I can tell you that a woman with a history of heart failure from her pregnancy who gets pregnant again, even if she's fully recovered her heart function, her risk of that recurring again is 25%. And so that means a 25% risk of death of needing a heart transplant or being permanently disabled or on a left ventricular assist device because of her pregnancy. To me, that is definitely high enough to recommend an abortion, but other people would not agree that 25% is high enough. And so, what number is high enough? How high does the risk of death have to be before we can say that it is a medical emergency? And that's not necessarily well defined. I would say this country's maternal mortality rate is about 20 per 100,000, so 0.02%. And we've declared a crisis of maternal mortality in our country because that number is rising and it's unacceptably high. So to tell one patient, well, your risk of death is only 1%, you can't have an abortion seems ridiculous, when I think a patient should be able to say for herself, I think 1% risk of dying is too high, I want an abortion. And even when you have a panel of doctors, which is just, I think, disgraceful to say that a patient can have a medically indicated procedure, it doesn't actually protect you that well from SB8 because that's a civil lawsuit. So anybody could come along and say, I disagree, I'm suing. And you might win your case, but you're still tied up in a lawsuit, which is kind of every OBGYN's worst fear anyway.
Thank you. Thank you. And I know we're coming up upon time. There is a question from a medical student, and I want to read it to you. And it says that as a medical student, this legislation is scary in terms of impacting the training we can get, in addition to the adverse effects on women in Texas. Do any of the panelists have suggestions on how to combat this legislation through research, and advocacy as a student?
Well, I actually think our med student pointed out something really important that we hadn't touched on at all, which is that our training, our students in training, our residents, our fellows are not going to learn how to do these life-saving procedures. They have to go elsewhere to learn. And that just means we've depleted our workforce, which honestly already we did not have enough providers that knew how to do some of the more complicated procedures. It's incredibly damaging. And in terms of who we can recruit to come work here now and train here now, I think we've really limited who's willing to come to Texas to learn. But I will turn it over to, I think, Abigail and Lauren will be able to speak much better on advocacy.
I want to continue with the teaching because that is part of my role as a faculty member at Dell Medical School. I train our residents in OBGYN, and I think that this is a really important point, the impact on training and the fact that restrictions and availability of training could very well outlive policy change. If you do not have any doctors who are trained to provide abortion care, then even if SB 8 or SB 4 falls away, if you don't have anybody to provide these procedures, it doesn't matter. It doesn't change the actual access for patients. So I would say to you, you're a medical student. Your job is to learn, and that job is so full and rich and awesome. Just steep in it. It's amazing. But my ask of you is that you make part of that learning this, because half of our population is capable of pregnancy. This affects many people that you will see on an everyday basis, no matter what you do in your career. And so I would just ask that you make this part of your training.
Really quickly, I think that in addition, sort of over and above of your role as a medical student, and I guess I'm speaking to everybody when I say this, is that talking about these issues is incredibly important. You know, even though we're so aware of this sitting in this room tonight, not everybody out there is thinking about it or aware of it or seeing where this is going on a national level, or what might be coming up the next time our legislature is ready to sit. And I think that when we think about what we can do practically as citizens and people who live here, we can talk about it. We can tell people that you still have the right to choose abortion in this country. You still have ways of accessing that care, should you want to or need to. And we can all help support abortion funds and clinics. These are nonprofits who really need support. And so any of us who are feeling philanthropic, our donations go a long way.
Thank you all. I could keep listening to you, but this isn't just our conversation. So I'm going to take this back to JR and ask you to close us out.
Jewel, thank you so much for doing a terrific job of moderating this evening. You know, as we close this evening's symposium, I want to express a warm thank you to Doctors Mullen, Aiken, Thaxton, and Harper for sharing your expertise and your experience with us tonight. And a big thank you also to the Dell Medical School for supporting this event. All of you in the audience who registered for this event will receive probably by tomorrow a link to the LBJ YouTube station, which will have a recording of the event, plus some of the articles that were mentioned today are referenced. And then lastly, I want to thank each of you participants who have joined us for this conversation. Thank you for your interest in learning more about this policy area, these issues, asking questions. I look forward, and we look forward here at the LBJ School to an ongoing dialogue about the reproductive health policies that really center Texas women and their families in our community. Thank you all and good night.